This is going to be a very short and crisp and detailed video on men syndromes. Men means multiple endocrine neoplasia. How do you remember men as autosomal dominant or recessive? Men are always dominant. So that's why you can remember autosomal dominant from men. Men is abbreviated as a multiple endocrine neoplasia. But it is not a right way to say it as a multiple endocrine neoplasia because it does not actually give you clue about what it is by looking at the name itself. Of course, the name is multiple endocrine neoplasia. That means not all endocrine systems are affected, but multiple. That means a lot of endocrine glands are affected. That's what the name suggests. But it does not tell you specifically what it is actually. So that's why, according to me, if you ask me what its name should be, its name should be MRMS. That means menin ret mutation syndromes. This is not given in any books or anywhere. I have myself coined this term as a MRMS for my understanding. At least the name itself is telling that men in ret having endocrine glands are affected. MEN1 is a gene that codes for menin. RET is a gene that codes for a tyrosine kinase receptors. The glands which are regulated by these genes are also affected. Based on the menin or a RET mutation, it is classified as a MEN1 or a MEN2 syndromes. If menin is affected, that means MEN1 tumor suppression gene is affected, then it is called as a MEN1 syndrome, also called as a Wermer syndrome. If RET gene is affected, that means tyrosine kinase receptors are overactivated, then it is called as a MEN2 syndrome. MEN1 syndrome, the affected endocrine glands you can remember as 3Ps. That means parathyroid, pituitary, and then pancreas. So what happens if these glands start working very hard? That means tumor suppressor gene, that is MEN1, is suppressed. That means tumor suppression is no more existing. That's why glands start secreting more and more, working more and more. That gives rise to parathyroid overactivity, pituitary overactivity, and pancreas overactivity. What happens if these glands are overactivated? If parathyroid is overactivated, then parathyroid hormone will increase. If parathyroid hormone is increased, serum calcium will increase. Bone resorption leads to increased serum calcium in the blood circulation. Because of the increased calcium, there are increased formation of kidney stones. Since calcium is more, there is abdominal pain and constipation because of the smooth muscle will no longer work as efficiently as before. That leads to constipation. Psychic moans, this shows up as a lethargy, confusion, and depression. Apart from these, increased parathyroid hormone, that is serum calcium increasing, will lead to the QT interval shortening and polyuria, polydipsia. So these are the clinical features of parathyroid hormone overactivation. If anterior pituitary is affected, then there is a prolactin increase, growth hormone increase. Prolactin will lead to the galactorrhea, and growth hormone increasing will lead to the acromegaly. Now coming to the pancreas, if it is overactivated, that means there are secretions that are more in the circulation. Which are these secretions? VIP, insulin, and gastrin. If these are overproduced, then it leads to VIPoma, insulinoma, and gastrinoma respectively. If VIP is increased, that means there is increased water secretion into the GIT. That will lead to the diarrhea. Along with the increased water secretion, there is a increased electrolyte excretion. That will lead to decreased potassium, decreased chloride in the blood circulation. So there is a dehydration, diarrhea, and electrolyte imbalance because of the increased VIP, that is VIPoma. Now, if insulin is increased, that means insulinoma, there is a hypoglycemia. If gastrin is increased, that means gastrinoma, then it causes something called as a Zollinger-Ellison syndrome. That is ZE syndrome, which leads to the peptic ulcers. Now we'll come to the MEN2 syndrome. As we have discussed before, if a MEN1 gene is affected, that is menin, which is a tumor suppression gene, which is suppressed, leading to the increased activity of a endocrine gland. Now, if RET gene is affected, RET gene is a proto-oncogene. If it is overactivated, then there is a no break to the production of secretions by the endocrine gland. That will lead to the MEN2 syndrome. There are two types of a MEN2 syndrome, which is MEN2A and MEN2B. MEN2A is a Sippel syndrome, also called as a Sippel syndrome. Which glands are affected in which kind of a MEN syndrome is decided by embryogenic origin. So, neural crest origin tissues are a thyroid, that is parafollicular cells, and adrenal medulla, and also neural tissues. In MEN2A, there is a thyroid and adrenal medulla which are affected mainly. Among the thyroid, there is a parafollicular C cells which are affected, which are overproducing the calcitonin, leading to the medullary thyroid cancer. This will in turn leads to the increased calcitonin production. The treatment for this condition is a early thyroidectomy. Adrenal medulla is also derived from a neural crest. It has RET or proto-oncogene as its main regulatory hormone. Adrenal medulla by chromaffin cells increases the catecholamine production. That will lead to the condition called as a pheochromocytoma, where there is a hypertension, sweating, and palpitation. And thirdly, there is one overlap between the MEN1 and MEN2 syndrome, that is a parathyroid hyperplasia. In men 1 and all as well as a men 2A, there is a parathyroid hyperplasia that occurs. If you ask me what is the percentage of risk in each of these three, then I will say there is a 100% risk of a medullary thyroid cancer if you have a men 2A syndrome, and there is a 50% risk of a having pheochromocytoma, and there is 20% risk that the parathyroid will be overactivated. That will lead to the parathyroid hormone increasing, in turn leads to the increased serum calcium. This is about the men 2A, which is a Sippel syndrome. Coming to the men to be, if I have to say the difference between men to A and men to B, then it would be neural tissues. The thyroid will be same as we have discussed in the men to A, that is a increased calcitonin production, and as well as adrenal medulla, that is a pheochromocytoma, as compared to the men to A. Now the difference comes is a neural tissue origin. If neural tissue is defective, then there is a connective tissue defect which will lead to the Marfanoid habitus. That means it's not exactly Marfan syndrome, because the Marfan syndrome etiology is completely different. It is caused by fibrillin 1 gene defect. But here it is a neural tissue defect, which is a connective tissue defect, which looks like a Marfan syndrome, but it is not a Marfan syndrome. It is called as a Marfanoid habitus. The features are same like Marfan syndrome. One more neural tissue derivative which leads to the mucosal neuromas. These mucosal neuromas are a painless nodule, occur in the lips and tongue and gastrointestinal tract. If I have to say in summary, gene that is affected in MEN1 is a MEN1 gene, and in MEN2 there is a RET gene affected. In MEN2 there is a MEN1, there are three P's which are the parathyroid, pancreas, and pituitary. In men2, where RET gene is affected, which is a proto-oncogene, there are two kinds based on the which gland is affected. It is a men2A and men2B. In both the cases, there is a neural crest origin endocrine glands which are affected. Those are thyroid glands and adrenal medulla mainly, and neural tissue derivatives. In men to A, the difference comes with the parathyroid gland, and men to B, the difference comes with the mucosal neuromas. So this is whole and soul the concept of men 1 and men 2. Now the question comes, if you have listened the lecture properly, we have said that there is a thyroid, medullary thyroid carcinoma leading to the increased calcitonin, and as well as we have said that the parathyroid hyperplasia leading to the increased parathyroid hormone. Now increase in calcitonin will decrease the serum calcium, and increase in parathyroid will increase the serum calcium. Now, if I have to think theoretically, then both these effects should cancel out each other and there should be normal serum calcium. But this doesn't happen because the calcitonin effect is not that powerful as compared to the parathyroid hormone. This is why the action of parathyroid hormone will dominate over the calcitonin, leading to the net increase in the serum calcium. So this is the concept behind men syndromes. I hope you have liked these videos. If you want me to continue further these conceptual videos, hit that subscribe button because it is much needed at this point of time where I am starting out. Thank you for watching, and I'll see you in next video.